So I'm just going to go, like Andy said, through chest x-rays. We're also going to talk about abdominal x-rays. Most of you have obviously looked at millions, so we won't really dwell too much, but the things that we need to talk about today are how you can approach these things for the exam, how you can present them, because I think that's something that a lot of you worry about. So we'll go through them. And then a few written exam questions, like this one. So we'll start with this. So hopefully you can all read it. And then I'll give you half a minute or so. Okay, for the first one, 72-year-old man, acutely short of breath, PE is suspected. What would we do? So CTPA is, which one's that on this? E? Anyone, anything different? No? I think that's straightforward. Next one, 65-year-old woman, short of breath, heart failure suspected. Got a few mumblings. Anyone confident? A? Yeah? A. So we need a PA chest x-ray. And so erect I don't think really matters, but it's the only PA chest x-ray, so that has to be the answer. 3 42-year-olds with rheumatoid arthritis, perforated ulcer. Yeah, A, because it has to be an erect chest x-ray. It doesn't need to be PA, so kind of trick. 22-year-old gallstones. Ultrasound, yeah, so whatever that is. C, and then a 15-year-old with appendicectomy, bowel obstruction. So we've got H or D. Oh, 50-50. So someone who's saying H, you were saying H, why H?
Consultant said to us that they always find the level with
Say it again.
They said always find the level of the obstruction with CT.
Yeah, so always find the level of obstruction with the CT, but how do you diagnose the obstruction? With an abdo x-ray. So completely right. You can kind of make a diagnosis of, you need to make a diagnosis of obstruction. You can on an x-ray sometimes see the level, but you're right to say to be sure where the level is, you need a CT. But it will say to confirm the diagnosis of obstruction. So this is probably the standard for finals, not much harder than that. The only thing they might do is not make it as easy saying a PE is suspected. They might give a longer blurb with something like their SATs being low and things like this, and so you have to imply the diagnosis before then choosing. So it'll be like one more level, but that's sort of standard. So most of you know the structure you give of structure to use when looking through a chest x-ray. So we'll just go through a few of the details. So you look at the details, then you need to know how to assess the image quality. If there's an obvious abnormality, like I said with ECGs, I think it's better to let the cat out of the bag. It makes you all feel more comfortable. It's what you do in real life, so I think that's what you should do in exams. If you prefer, you can go through your systematic way and come to the abnormality when you do. And then really importantly to correlate this with the scenario they give. So what details on this? So this is a chest x-ray, and I've just zoomed in on the details. What stands out? What's important here? So it's in resus. So supine. There's only one other word. So mobile. So when do you use a mobile chest x-ray? When they're really sick. So if it says this, I think it's really important to say it's a mobile chest x-ray in the supine position. It's better to do it standing up, which we'll come to, or sitting up. So it's supine, which means you need this chest x-ray, and you know it's not going to be optimal quality. And they're in resus, so you know they're sick. And then obviously all their name, date of birth, and when it was done is obvious. So PA chest x-rays are better quality, but they're logistically more difficult. So the patient has to be sitting upright or standing up like this, and then the x-ray comes from behind, and you get a better quality or a more accurate image of the heart. So PA is optimal for some people too old, too ill, or a lazy radiographer. You'll get an AP chest x-ray, which isn't ideal, especially for monitoring, for measuring the heart. So these are two images of the same patient. AP, you could say, you'd probably think that was cardiomegaly, wouldn't you? Whereas actually the size of the heart is normal. So just really important, if you're going to comment on the size of the heart, you can still comment on it, but you have to give the caveat that it's an AP film, if it is. So in terms of the image quality, there's loads of ways you can do it. I prefer the ways RIP as an acronym, so rotation, inspiration, and penetration. So for rotation, it's really important. If you have an object that's not symmetrical as a sphere, like the heart, and you look at it directly on, and then you turn it, you're going to see a different size of that asymmetrical image. So if you see here, this is a patient who's completely square on, and so the heart's this shape, and you'll get the image of the heart here, the white line, which is about accurate for the size of the heart. And again, the same size heart, if you just twist the patient, you're getting a kind of skewed view. So you might think that the heart's bigger, so cardiomegaly, when in fact it's not, it's just the patient's rotated. So how do you assess for rotation? So clavicles and the spinous processes. So we're all happy with that? Yeah, so this image, is it central or rotated? Central. Yeah. So just zooming in on that, so for those of you who weren't sure of it, so the clavicles you can see, and then these spinous processes, and they're pretty much in the middle of this image. So then you can move on. So for inspiration, so which is, so again, two of the same patient, one in expiration, you might say that you might comment on blunted costophrenic angles, you might talk about the kind of the haziness, potentially you could call it consolidation, where in fact it's just the patient hasn't taken an adequate inspiration. So how many ribs should you see in an adequate inspiration? So we've got 6 anterior. Do we all agree with that? Yeah? So yeah, between 5 and 7 is what is called normal, so call 6. And the anterior ribs, so I think you can see it better on these ones, but it's so small. It's a pretty poor image, but there's 1, 2, 3, 4, 5. So I'd say 6 maybe anterior. Oh yeah. Thanks, Andy. Some mood lighting. That's quite. Get in the mood. Just need some jazz music on. Get the chest X-rays out. Okay, so anterior ribs we were talking about, yeah. So penetration. Oh, right on cue. So, lost my place now. So many innuendos. So, why is this one? Someone talk me through these. Why is that underpenetrated? So, not enough X-ray. So, and how would you assess that a bit more objectively? Yeah, exactly. So you need to be able to see some of the spinous processes behind the heart. And this one you can see you're only seeing black, so it's just over-penetrated. It's just going all the way. The whole X-ray is going through the image, so you can't assess the actual lung fields. So that's those RIP. Just need to quickly do it. It'll take you 1 minute, and then when you're presenting, we'll come on. You don't need to go into depth about it unless they ask. Most likely they're going to give you good quality images, for if they bring it up in an OSCE and you're presenting, because it's more kind of detailed. So we'll go on to the actual X-ray now. So I won't dwell on this too much, but just a few points. So the location of the fissures and the names of the fissures is just useful to know. So especially this horizontal fissure, which we'll come on to for the middle lobe. What else is useful? So the gastric bubble here. So that's just like an air fluid line. So obviously there's some fluid in the stomach, in the air fluid line here. I don't think there's anything else there. So looking at the bones and soft tissues here, what's the abnormality? Left breast is absent. Spot on. So you can see, we're not looking at the lungs here, this about the soft tissue. So the breast is here and there's no breast here, so we've had a mastectomy. Okay, so what tube is that, and is it in the right place? So NG tube, and it's obviously in the wrong place, and they've fed through it. So this is some food. So we're happy with this, yeah? You can't really see it coming down, I do accept, but the new NG tubes have a radio-opaque tip to them, so you can see exactly where it's ending up. And then, so how do you assess where an NG tube should be? If you're doing it on the ward. So you can check the aspirate. So is that the first line or second line? First line. And what do you check it with? pH strip or not litmus paper. Okay. So in the olden days, they'd just get their litmus paper out, and I don't know why they'd carry it around, but apparently there's some dodgy litmus paper. So you're not meant to do that anymore, and it has to have an acidic pH on a pH strip. And then if you're not sure on that, then you do a chest X-ray, and then you check. All these other things like the bubble test where you shove air down it and listen for bubbles, that's not allowed, or the colour of the aspirate, that's not allowed because apparently respiratory content can look like gastric content. More lines. What are the lines on this one? So ECG, yeah, and a chest drain, yeah? So you can see the pneumothorax on this side. Lung fields here. No lung markings here, sorry. And the chest drain here. And that's ECG lead. And then this one here. No, central line, yeah. Okay, so just coming on to some cases. So this is something they could give you in finals. They'll give you a one line, or what they could do is a respiratory OSCE, and then at the end give you a chest X-ray to present, or in the practical stations they could do something respiratory like an ABG and then a chest X-ray, and you present the chest X-ray. That's come up before. So who wants to present this? No one. Anyone? Awkward silence. We can help out, so someone do the first bit of how you present it. Fantastic. Carry on. Well, anyone carry on? You were doing perfectly there, so why don't you try? Yeah, good. So we'll just summarise that so far. So the introduction, this is a PA chest X-ray of Mr. Andrew Smith, either say his date of birth or work out his age, 28-year-old gentleman and this is a chest X-ray done on today at 6 o'clock. And then we're talking about the quality. So we talked about the the rotation, inspiration, and penetration. Or if you've already done that already, so you'll have time to look through it, you can say this is a chest X-ray of adequate quality, and then carry on. So that's perfect. And then...
So just looking, there's no blinding obvious abnormality. Well, there is actually. So the most obvious abnormality is the rapacity in the left vein. The border of the heart is clear, apart from on the left, where I can't see the cardiophrenic and postoperative angle clearly. On the right, both angles are clear. The hyla looks fairly normal. I can't see any abnormalities with the bones. Can't see any mass behind the heart. I think it's the capacity from the lower lobe, which could be a lower lobe pneumonia on the left.
Yeah, perfect. Round of applause for that. A diagnosis which is easy, but just to see the presenting of it, that was really, really good. But it's quite difficult to, when you're presenting it, to go through everything. So I've just put, it is small, but I don't know why it's really blurred. But it's just to go through things. So your introduction, to include the patient's name, age, and the time when it was. Image quality, you could just say it's adequate. Main abnormality, which you described, was the left lower lobe consolidation. And then I think it's reasonable to go through your approach, how you go through everything. So talk about the trachea being central, the mediastinum, compare each side of the lobes, and the heart size and the costophrenic and cardiophrenic angles, which you mentioned. And then just mention there was no obvious abnormalities of the soft tissue or bone, which you didn't mention. But so go through that. And then, again, like everything, like you do in OSCEs, like we keep talking about, then you say, in summary. So rather than just stopping there, because the examiner will have some difficult questions or difficult ways of asking the question. So then you say, in summary, this is a chest X-ray or chest radiograph, which demonstrates evidence of left lower lobe pneumonia, which is consistent with the clinical picture. So in this one, they gave you a clinical scenario of a cough, fever, and raised white cell count. So this would go along with the pneumonia, wouldn't it? So you can say either it does correlate, and for OSCEs, make sure it does correlate, because they're not going to throw something that doesn't correlate. So this is consistent or correlates with the clinical picture. And then if you want to avoid any further questions, you can say, my investigations for this patient would be to take full history, bedside blood tests, imaging, and special tests. My management would be some antibiotics. And then you're done. They can't ask you any other questions. There won't be any other marks. So does that make sense to everyone? Is everyone happy with that? Yeah? Because it's easy to pick up the abnormalities on a chest X-ray. I think it's quite difficult to present them. So take a picture of that on your phone, or it'll obviously be online, and get it right. So we won't present any more, because obviously that takes a bit of time for a lecture like this. So just some spot diagnoses. What's the main abnormality? So sail sign. We've all heard of that. So this apparently looks like a sail here, the heart. So and that's a sign of what? Left lower lobe collapse. Yeah. This one. So what's the abnormality here? Yeah, good. So do we all see this? Fluid in the horizontal fissure. So that would be... You all see that? Yeah, so the costophrenic angles are clear. You can't really see this one. The rest of the chest looks clear if you compare. But if you're comparing the middle of the chest here in the middle, there's this line going across. So what's that a sign of? So in a patient who's got a productive cough with a fever. So, but, yeah, right, middle lobe pneumonia. Okay, so consolidation is probably the most common chest X-ray that you're going to, heart failure. So I think it's obviously not that difficult. Most of you have seen it, but just make sure you're comparing the right to the left. Check the angles, the costophrenic and the cardiophrenic angles, and then you won't miss any subtle signs. And just check that right middle lobe, because that's probably the one that most people miss. So what would you say of this? So you're saying hyperexpansion. Anyone want to agree or disagree with that? Okay. Again, maybe better to look on these ones, because for the subtle signs. So just while you're looking there, just count the anterior ribs. 1, 2, 3, 4, 5, 6. So the anterior rib stops here, 6th one, and it's the one that crosses the diaphragm. So it's not actually, although it does look hyperexpanded, in terms of the ribs, it's not. Okay. Left pneumothorax, apical. Okay, so do we all see this? So it won't be as hard as this, but it might be, this would be reasonable. So the clinical information saying that someone's fallen from a height, trauma to the chest. So then you would, the reason I put this up is then, like with an ECG, you're looking for that abnormality. So you're not going to get this story, and they're not going to now give you a COPD patient, because it doesn't fit. The clinical scenario is of someone who you're going to be looking for a pneumothorax. Where's my cursor gone? And you see up here, so there's no lung markings here, but there are lung markings here. So a left apical pneumothorax. And then extra marks for anyone? What else? Sorry? Due to a fracture. Awesome. So you see here, this rib here is fractured. So it's fallen, fractured the rib, caused the pneumothorax. Then what's the next question you always ask? Pneumothorax, what's the next question? Is it a tension pneumothorax? Is this a tension pneumothorax? No. Wicked. So yeah, you see the mediastinum central, the trachea central. Whereas that one, we're happy it's a pneumothorax? Yeah? Tension? Yeah. Okay, so you see the mediastinum's coming across here. Okay, so with pneumothorax, again, and with all chest x-rays, you're just comparing like for like. And then make sure you look for the tension, and then look to see if there's any bony or soft tissue abnormalities underneath. So this is the sort of one that, imagine if you walked into an exam and you start talking about the bony abnormalities, the inspiration, and you talk about everything else, and then you come on to the bit where you talk about the abnormality. I think it's just a bit more mature to say this is the main abnormality, and then I'm going to go through my systematic approach. So what's the diagnosis? Pleural effusion. So why are you sure of that? Yeah, so there's a meniscus here on this side. And if we gave this clinical information, yeah, so due to malignancy. So again, just think how you present it. So it's easy to do the introduction. You can just copy what we said for the introduction. The quality is probably a bit underpenetrated, but you don't really need to go into that. The main abnormality, and then when you're doing a summary, evidence of left pleural effusion in keeping with the clinical information given, likely a underlying malignancy. So more subtle effusions, like you all know, will just be of the blunting of the costophrenic angles. So another one, so 69-year-old smoker, progressive shortness of breath. Without seeing the X-ray, what's it going to show? COPD, yeah. Sorry, it's not COPD. Or heart failure, which is this one. So what are the abnormalities on this X-ray? Yeah, so we've got alveolar edema, cardiomegaly, curly B lines. Yeah, so we all know the acronym. So again, this is a sort of scenario that might come up. What's the likely cause? And so what are the abnormalities for likely cause? We said heart failure and appropriate imaging. What would be the next imaging you'd advise? An echo and the follow-up. And then you talk about your management of heart failure. So the A, B, C, D, E approach to X-rays, you all know of heart failure. So, and this is it demonstrated on that X-ray there. Very tall. So, diagnosis or thoughts? Yeah, so COPD. So again, you have the scenario. It is difficult to see the anterior ribs on this one, but trust me, I can't. On the screen here, you can see them, and it does look expanded, and the flattened diaphragms here. Okay, and what? So you see, there's these black areas here. What are these? So bullae. Yeah. So bullae of COPD. Okay. So how would you describe the abnormality? So before you say it's TB. So cavitating lesion, and then you say where it is, central area of necrosis, and then in keeping with this clinical scenario, you'd think it was TB would be the most likely diagnosis. So then you'd go on to, my investigations would include sputum, blood tests, etc., my treatment would include, and then you go on to your treatment of TB. Oh, I don't know why that's the really useful slide of how you get your marks in the OSCE has not come out. Brilliant. I'll sort that out so when it's on the website it will be. But yeah, this is what they look for in OSCEs. It's not rocket science, mostly what we've said before. But these are all the marks they can give you. They give 1, 2, or 3 out of these. So yeah, that's how you pass. Simple. So pub quiz. Marilyn Monroe. This was her chest X-ray in 1954. It sold in an auction in 2010. How much did it sell for? I'll buy a cake for whoever gets it. 5 mil? What? 20,000. 20,000. You'll get a cake. So, 20 mil. 45,000 pounds or dollars. It's sitting there somewhere. Okay, so moving on to the abdominal X-rays. So we're showing a chest X-ray, obviously, like you all got in the EMQ. So how would you describe this? We obviously all can see the air under the diaphragm. How would you describe it? It's a pneumoperitoneum, and it needs to be an erect chest X-ray. How long do they need to be? I was going to say, how long do they need to be erect for? How long they need to be upright for? 2 minutes? 10 minutes? Yeah. So 10 to 20 minutes, ideally. Obviously, if they're more acutely unwell, you can be quicker with it. But ideally, 10 to 20 minutes. So you can just sit them up in a bed if they're unwell, get it really upright, and then all the air will come from the bowels up. So who wants to present an abdominal X-ray? Anyone? We can't go for you again. No. Anyone from this side? Take a punt.
Extended loops of bowel, centrally.
So present it like so. It's yeah. Sorry.
That's right. So it doesn't have a name or a date or any of those things.
Yeah, forgot to put them on.
This is abdominal X-ray with reasonable penetration, and the major abnormality is distended loops of small bowel centrally.
Yeah, okay. And if I gave you the clinical scenario there,
Most likely obstruction.
small bowel obstruction. So very good. So again, the initial bit of your introduction, who it is, where it's done, when it's done, stays the same, and a reasonable quality film, and then the main abnormality of small bowel obstruction. You can go on then to talk about, we'll just quickly mention. So small bowel is when it's above 3 centimetres. Large bowel is above. So again, this is a slide, I won't go through it because I'm aware of time, but it's much the same. Abdominal X-ray is much easier than chest X-rays to, one, interpret, and two, present, because there's less to look at. So main things you look at in your approach is, so the small bowel, the large bowel, if there's any gas anywhere else, and then the soft tissue, including the bone. But again, summarise it, then go straight on to what your investigations would be, and then your management. It just means they can't ask you any questions. So just quickly now, so single best answer. Adhesions, good. So main causes are adhesions, malignancy or hernia, but in this case it would be adhesions. So post-op abdo distension, no flatus, what would you be thinking of? So post-op, unless there's been damage to the bowel, it's more likely to be ileus. And the X-ray, you can see the loops of bowels, but they're not distended. So that's a picture of post-op ileus rather than obstruction. Whereas this main abnormality. So small or large bowel? The large bowel. Okay, and so the most likely cause? Cancer. So then you'd go on most likely cause, and so my next stage would be what would your next imaging be? So colonoscopy or a CT. So neonate comes gastric dilatation on an X-ray. Most likely cause? So volvulus. Good. And that is volvulus. So it's apparently meant to be a coffee bean sign, which I think you can see in this one. Often you can't. You see here, it's like a Costa coffee bean. Okay, so what are these three images suggestive of? One condition. So ulcerative colitis. So what would you call this? Thumb printing. It's like your thumb is being put in the bowel loops. This one. Lead piping. It's like holding a lead pipe. And this. Yeah, brilliant. So toxic megacolon. So all signs of UC. Poor thing. So cephalic. You can say. So yeah, see, there's a baby. So the OSCE marks. So again, this is much the same. So like we've talked about, and in the marks comes the management plan and your next imaging. So make sure you do mention it, otherwise they'll ask it in a difficult way. Quickly, how do you know this patient's old? Pessary, here. Anything else? Constipated, all old people are constipated. Next. Osteoarthritis, and there's some calcification. What's that? That's it's an egg. That is the world's largest kidney stone. I'll leave these for you to go through. We quickly do them. So bile stayed vomiting in a 4-day-old. We've already said that, volvulus. This one, 65-year-old man, rectal bleeding and large bowel. Answer. So C. 65-year-old with abdominal pain. Adhesions. Adhesions is the answer, yeah. 49-year-old acute air under the diaphragm. It's much the same as the one before. and 49-year-old abdominal pain, small bowel dilatation, and air in the biliary tree. So gallstone ileus. I found this. So read this story. This is a 60-year-old man who checked himself into a hospital in Pakistan. He sought treatment because he claimed thieves had inserted a Pepsi bottle into his anus before stealing 2 of his buffalo. Poor chap. That is really bad luck. Okay, thank you very much. That's all.